Thank you, Travis. Thank you, Jared. Thank you, everyone, for organizing this and inviting me. For those of you who went to University of Tennessee and you're like, who's this person? I don't know her. I am brand new. I just started there in the fall. And so I'm really excited to be here today, partly because this is my first time in Nashville. I've never been there before. It was a really easy drive, so I'll be back. And second, it's nice for me to get a chance to sort of meet the new folks and the existing folks in the health law space who practice in this area. So I put my email at the end of the presentation. Please always, feel free to reach out and introduce yourselves. I'm always excited to meet other people in the field. Okay, so when I was asked to give this talk, I very much thought that this is a primer, and so the idea is that hopefully most of you are pretty new to the field of health law. If you aren't, you're gonna be bored because this is pretty basic stuff for those who are kind of old hat at this. But so I thought about the idea that if you were an alien, right? If you're an alien who just drops into the earth and you have to understand the US healthcare system, what exactly do you need to know? And as I tell my students all the time, it's an exceedingly complicated system. If it were a simpler system, I could probably talk about it in about 5 minutes. And instead, it could take 14 weeks to really explain how the system actually works. Okay, so what am I going to touch on? I'm going to give you a basic overview of how the healthcare system is structured. I'm going to talk about the finance piece, how individuals obtain and maintain health insurance in the United States. I'm going to talk about a little bit about how healthcare services are delivered, and then just a very brief dose of kind of the legal and regulatory pieces that come from all of this. I'm approaching this very high level, so you sort of understand the system and how it interacts, and then how that bleeds into the kinds of issues that you as lawyers will be facing. Let me start with, and I will tell you, I'm guilty of using Claude for a few of my slides to really jazz them up. I'm AI experimenting, so just so you know, when there's a few that look maybe pretty polished, it's not me. It is totally AI. Okay. So I always like to start these talks by thinking about the kinds of healthcare systems that could exist in the world, okay? There's a really nice study from T.R. Reid who explains sort of the 4 models of healthcare systems that exist in the globe, okay? So the 4 different ways that you can kind of broadly organize healthcare. One is beverage, and so beverage is a system where the healthcare is both delivered and financed by the government, okay? And the most famous model that you can think of here is the United Kingdom, okay? The majority of doctors are government employees. They receive their paycheck from the government, and the government finances the healthcare system through a general taxation. Akin to that, right, and on your right, is the National Health Insurance System. So this is similar in the sense that it's financed by the government, but very different in the sense that the care delivery takes place through private actors. So the Canadian government, as an example, pools its money to pay for its national healthcare system, but it contracts with private providers to deliver the healthcare. The third model, which Germany is a good kind of typical example of this, is Bismarck. And all of these names come from like the old people long ago who invented them, right? So Otto Bismarck invented this model in Germany. And this is largely a privately delivered, privately paid for healthcare system. Now, it's not quite as simple as that, right? I'm boiling this down. But at the end of the day, Germany is different from the UK or Canada in the sense that it is largely privately delivered. A key dimension to their private financing is that it's largely nonprofit private insurers who essentially function in an administrative capacity and are given a lot of regulation about what they can cover and who they cover. And then lastly, I don't even like to call this a system at all, right? The out-of-pocket model, it's really no model at all, okay? So in more kind of developing nations, you'll see people bartering for healthcare, people spending out of pocket for healthcare, but really no formalized system either of public or private actors that are delivering the care. Okay, so why do I care about this so much? I put up a little American flag, right? What's going on in our system? Which system do we have? Let me just open it up briefly. What do we have in the US? You see, because I'm a law professor, I get all Socratic on you. You're like, no, I forget, I don't want to go back to those days, right? What do we have?
Hybrid. Combination.
That's okay. Well, you could just leave. You don't need to be here for this talk. No, I'm kidding. Yeah, it's a hybrid, okay? So we have, and not just a hybrid, but we have all of it. We have a little bit of everything in the US, right? So over here, the UK, public delivery, public financing, you can think about our VA system as probably a good example of that, okay? Government hospitals, governmentally paid doctors. The Indian Health Service is a little more complicated, not quite the same, but a similar kind of model. On the Bismarck side, we have our employer-sponsored insurance, which is probably what most people in this room have. That's the dominant model of insurance in our country. Up here, akin to Canada, we have Medicare and Medicaid, and then the uninsured are our out-of-pocket folks, right? The people who don't really have any sort of system that's serving them currently at all. There is a price to this, okay? This leads to regulatory complexity, legal complexity, it leads to consumer complexity, and it leads to a lot of inefficiency because of the fact that we have such a diverse model of healthcare financing. Okay, so let's talk a little bit about how our system performs relative to others before we get into the nitty-gritty of how our system works. So for a number of years now, the Commonwealth Fund has done a report called Mirror Mirror, and they look at 10 economically developed countries to determine how their healthcare systems stack up on a variety of performance metrics. And for those of you who are familiar with these issues, or maybe not even so familiar, it probably won't surprise you to see that the United States is, at the very top when it comes to spending. So we spend more GDP than any other economically developed country in the world when it comes to delivering our healthcare. So you would think that we might be one of the better systems. And, if you ask people on the street, they'll gripe, but largely, I think most people, when polled, say they're pretty happy with our healthcare. The problem is that the US healthcare performance is actually quite low relative to these other economically developed countries. The Commonwealth Fund looks at a host of metrics to determine this. Now, what I will tell you is where we excel is in having a lot of high-tech equipment, right? A lot of specialists. We also excel in a metric that they call care process, which goes to sort of how people feel about whether they're heard, whether their voices is heard in requesting care. Some of the functions of actually talking to a doctor, talking to a nurse on the ground level, those we do quite well. I think we're ranked number 2 in the pool. But in the other metrics, we do really poorly, okay? So when I say 10 out of 10, I don't mean like 100%. Like we're a 10, right? I mean we rank 10 out of 10, we're the bottom, okay? So we are the bottom when it comes to accessibility, we are the bottom when it comes to affordability, we're the bottom when it comes to health outcomes, the actual reason that we have health care, right? How are we going to do at the end of it? We're 9 out of 10 when it comes to administrative efficiency. And we rank 9 out of 10 when it comes to equity. The other bottom performer in those categories is Switzerland, and don't ask me what is going on with them. They would probably be mad that I brought that up, okay? But they're the one who seems to be sort of struggling. So, and of course, you know, this is not a global comparison of every healthcare system in the world. This is just these 10 that are all seen as sort of complementary in their economic development. And before I move on, I'll just say, I mean, there's a lot of reasons to sort of speculate why the US healthcare system performs the way that it does. Certainly one piece of it is just the complexity of the thing. When you have many different insurance brands or types, right, public and private, and people are pooled into all of these different risk pools, it's hard for insurance companies to barter down prices, right, because the population is segmented. It makes it for an expensive administrative cost because doctors and hospitals are having to contract with a host of different types of insurers. And so those are just a few reasons why, right, we have sort of a costly system in a number of ways. Okay, with that, how do Americans get their health care? Like I said, the dominant portion is the employer-sponsored insurance. This is your typical way of getting insurance for the working-age population in America, those 18 to 65. And we're going to talk about each of these in turn. Next comes Medicaid and Medicare, okay? So they take up a big portion of the pie, but of course don't cover everybody. And then we have a smaller segment, right, in the yellow, which is our individual insurance market, our ACA, Affordable Care Act, Obamacare market, whatever you want to call it. There's a teeny tiny segment that's military, our TRICARE system. And then there's a decent wedge, right, in blue, which is the uninsured. Right now, that's around 8%. You know, that's kind of fairly low for our country, but we, you know, have had certainly pre-Affordable Care Act, you know, 16, 18% uninsured. Okay, so that figure sort of fluctuates. Employer-sponsored insurance. I like to go really retro with this, like think about the 1950s, you know. It helps to think a little bit about why we have an employer-sponsored insurance model, why that's kind of our dominant model. It is sort of the origin of health insurance in this country. The idea that if you were going to get health insurance, it probably started as a plan that your employer gave you. This gained speed in the World War II era, when there was freezing of salaries to prevent wartime inflation. And so what could employers do when they couldn't increase wages and when half the population was going off to fight the war? What they could do was they could boost benefits. Okay, so they could attract workers through good benefits. And so one of the benefits that they started offering was employer-sponsored health insurance. Now that looks very different in 1945 than it does today, but that was the start. It got solidified with a bunch of favorable tax policies where it became attractive for employers to continue to offer those plans. Okay, so zoom forward today and we have this dominant employer-sponsored market. This is a large group insurance pool, so you know, insurers or employers are considering the risk pool as the population of the employees. Okay, it's not looking at any particular individual, it's looking at the risk of that whole, however big that is. It might be 20 people, it might be thousands of people. Okay, so it's a large group insurance. The premiums are shared between the employer and the employee, with the employer carrying the larger portion of the premium. We don't have a mandate that employers provide benefits in this country. We do have a quote-unquote penalty, right? A financial penalty if employers don't. And that came with the Affordable Care Act. And so for most employers who are larger, 500 employees or more, it makes good business sense to offer an employer plan. Who's left out of this, though, is employers don't always cover employee plans for smaller employers or even mid-sized firms, right? So if you're someone who's going to go work at the local coffee shop and the local coffee shop has 10 full-time workers, they're not going to be in the same position to purchase an employer plan as, a Fortune 500 company or something like that. So, when you look at who is getting this coverage, it tends to be people who work for larger employers. And it also tends to be that these plans are available to full-time workers. So individuals who work part-time for whatever reason, typically 30 hours a week or less, are not eligible for employer benefits. The Affordable Care Act mandates that children up to age 26 be covered under an employer plan. So if you have children, you've got to be thinking about when you get to retire, right? I think about that all the time. I had children kind of later, and I'm like, oh, boy, they're going to probably keep me in this employer plan forever. But so age 26, up until then, individuals are going to be on their kind of family plan. Spouses are not required to be on employer plans, but typically are. Domestic partners sometimes are, but it's less likely. Two of the primary legal issues, and I'm summarizing here because I'm trying to lay some groundwork for you. I can't get into kind of any great detail with any single one of these things. But two of the big legal issues that come up in the employer market for you to be aware of if you're newer to the health law field, one is HIPAA. So when you think of HIPAA, you probably think of privacy protections and the HIPAA sheet that you get that says that they're not supposed to share your information. But there's another dimension to the HIPAA law that dealt with non-discrimination in insurance, and it applied to group health plans. So HIPAA, when it was passed in the 90s, was actually only providing these anti-discrimination requirements to these large group employer plans. The Affordable Care Act brought this to the smaller markets later. So HIPAA tells employer plans that they can't discriminate based on health status in pricing and enrollment, in lifetime or annual limits. And I'm using health status as a kind of a generic word. The law is more specific about all the different types of health-based discrimination that an insurer might want to do. So things like genetics, pre-existing conditions, your health history, and the like. The other thing, and maybe there's an ERISA expert in the room, I don't know. I'm seeing some quirks, some smiles, so ERISA experts don't normally smile, so maybe it's not you. ERISA is the big federal law that governs employer plans benefits, and it covers health insurance offered by employers. It is a mess when it comes to these questions of what plans must follow ERISA or not, and whether they're exempted from following state law or not. It is a complex area of law, but to boil it down, what ERISA does is it provides some basic consumer safeguards in employer health plans, but also in pensions and other kinds of employer benefits. It creates a potential preemption structure where an employer plan might be able to follow federal law and thus not have to follow state law. And that can also control which remedies are available, the remedies provided by ERISA, or a host of state law remedies for an injured party, and of course the forum in which one sues in federal versus state court. Preemption is very complicated, but that's the heart of the matter, is you're fighting out from the insurer's perspective over whether you're going to get ERISA law, which is a lot softer and easier on you, or state law, which might be much more robust and damaging to the insurer. ERISA has a very complicated pathway that ultimately has been interpreted to mean that self-funded plans don't have to follow state regulation, okay? It's kind of the out. So especially if you're a large employer who can afford to self-insure and carry the kind of risk of healthcare on yourself, then you're going to be able to avoid state regulation and you're going to be an ERISA plan, okay, who deals in ERISA law. So be on the lookout for that. Those are kind of the two big buckets there. Okay, Medicare. So I'm kind of starting with size, right? But I'm jumping between public and private. So employer-sponsored insurance is our dominant private form of health insurance. Medicare is one of our two big public plans, and Medicare is designed for age 65 and up, okay? I don't like to say elderly because then people get mad, right? So age 65 and up, but also some other populations. Individuals who have disabilities with a work history are eligible for Medicare 2 years after they've established disability and are receiving SSDI benefits. And then people with end-stage renal and people with ALS are also eligible for Medicare. So Medicare, like Canada, okay, is a publicly funded but privately administered plan. The different parts of Medicare are actually financed through different sources, which complicates things. And we won't get into too much detail on that other than to say the hospital benefits, Part A, come from a Medicare trust, right, through taxation. Part B has a lot of premiums, right, that feed it and is a little more financially stable than Part A. So Medicare comes in really two forms. You can either be in traditional Medicare, which means that you accept Part A, Part B, and probably Part D. So Part A is your hospital benefit. So if you need hospital, if you need skilled nursing, if you need home health, inpatient psychiatric care, all of those are going to be billed through Part A. Part A is, everyone is automatically enrolled in it. There's no real premium typically unless you didn't pay into Social Security. So it's free, it's there, and it also has no insulation, no max out of pocket, right? Which I think always surprises people. There is absolutely no maximum out of pocket when it comes to Part A. So you can imagine that you could bankrupt yourself quite easily as an older person who has no max out of pocket when it comes to hospital benefits. So a lot of people purchase what's called a Medigap plan, and that creates sort of an artificial out-of-pocket limit for additional premiums. Okay, there's different cost sharing, but you're not going to kind of face, an unlimited out-of-pocket expense. Part B covers physician services and outpatient care. Okay, this one is elective. People have to elect to enroll in it when they turn 65. Some people don't because they still are working, have private insurance, are married, and have a partner who's getting private insurance. And the later you enroll, the higher your premium can become. And then Part D is a newer invention of Medicare. This is the drug plan. It's crazy to think that there was a period of time when Medicare didn't cover drugs, but there was, right? And now under Part D, they do. Folks can be on these three buckets, or they can be on what's called Part C or Medicare Advantage. This is the kind of privatized managed care Medicare, okay? You know, often when you turn 65, the current insurer that you have. Let's say you have United, you might get a pamphlet in the mail that says, hey, your health benefits are going to basically look exactly the same. Just go under United, right? And you'll do Medicare Advantage for United, and you have a private plan that offers you benefits akin to Medicare. Primary legal issues here. And I'm trying, where's the clock? Is there a clock? Okay, you're going to just have to tell me periodically. All right, so some of the big issues when it comes to Medicare to be on the lookout, because this is federal law, you're going to largely be looking at administrative law matters. Okay, so administrative processes govern who's covered by Medicare. Administrative law processes govern the appeals process if somebody is denied benefits that they think they deserve. Administrative processes cover the question of what benefits Medicare agrees to cover, okay, through a process of national determinations, local determinations, one-on-one determinations. So all of this is going to be in the CFR, in the rulemaking, going to the Center for Medicare and Medicaid Services webpage, and looking up all of that information. There's also, though, a streak of private insurance involved in Medicare, okay? And so that brings with it, contractual law, that brings with it potentially other kinds of issues. So particularly Part D is a privately administered benefit, and then our Medicare Advantage or Part C is privately administered. Now these plans have to comport with federal laws and federal regulations, but they're also going to have, these contracts that they give to people that look more like traditional insurance and are controlling in that way. Okay. Medicaid. Now, I was simple when I said Medicaid is another program like Canada, where it's federally financed and privately delivered. Medicaid is actually a complicated system that has both a federal and a state component to it. The federal government typically pays more than the state, or it always pays at least the same as the state, but typically pays more under something called the FMAP, right, the federal Medicaid percentage. And this depends on the wealth of the state. The wealthier the state, the less federal support that they get. Medicaid is typically one of the biggest, if not the biggest, budget items in a state. So it involves federal and state money, but it's privately administered at the state level with state providers, private providers who operate in the state. The people who are eligible for Medicaid, this is an area where we've had some legal shifting, some litigation in recent years. There's more kind of political tumult around these questions. The very original Medicaid, right, was the kind of traditional Medicaid that was passed in 1965, envisioned what they called the categorically needy. And the categorically needy, this is their term, not mine, right? But you had to be two things. You had to both be poor, and you had to be seen as worthy, right? They called it the worthy poor, the deserved poor. You needed to be deserved of a public benefit in healthcare. And so the 1965 law defines that group as aged, blind, or disabled. Okay, so aged plus poor, blind plus poor, disabled plus poor. That original Medicaid Act was expanded to cover a few more worthy poor populations, including pregnant women, including households with children. But generally speaking, this was the kind of original intent of Medicaid. And if you're kind of following along, what you'll notice is that all of these programs are sort of plugging the gaps that the employer market leaves, right? So in 1965, we're looking at what people are not covered by the employer market, the elderly who are no longer working, that's where we get Medicare from, the poor, the disabled who potentially can't work, right? That's where we get Medicaid from. So we have this traditional population. They typically in the state have to qualify at around 75% federal poverty level, and they have significant asset limits, okay, of $2,000 per individual. We also have the pathway for the medically needy. The medically needy qualify for Medicaid by their healthcare expenses, once paid for, essentially making them as poor as the categorically needy, okay? So there's typically a pathway in a state where you can look and say, well, I spent $19,000 on out-of-pocket healthcare expenses in a year. When you subtract that from my income now looks the same as someone who is categorically needy, and you can qualify that way. In states that have expanded their Medicaid under the Affordable Care Act, which are the blue states, okay, we are not currently standing in one, right, that has, Tennessee has not expanded Medicaid. In the states that have expanded Medicaid, you no longer have to be worthy poor. You just have to be poor, and poor is defined as 138% federal poverty or below, okay? So in those states, the requirements of aged, blind, disabled, pregnant, have children all evaporate, and you can qualify based on income. Those populations receive a different type of benefits. The content of the benefits is different. You still have people who qualify for Medicaid based on categorical need, and those people are typically on SSI, okay? And of course, you're probably aware that the expansion became optional after NFIB versus Sebelius, right? And then lastly, a lot of people aren't familiar with this, but there's a category of people who are dual eligible. This means that they essentially are both eligible for Medicare and Medicaid. Typically, the two interact as like wraparound benefits, where when one doesn't cover something, the other comes in and does, or sort of supplements to prevent out-of-pocket costs for the individual. This is typically your low-income elderly who are qualifying for this. Oh, primary legal issues with Medicaid. Again, this is an administrative law area. It is complicated by the fact that there's going to be federal administrative law that's applying, as well as state administrative law that's applying. And so you need to be on the lookout for both, right, when you're dealing with anything in this area. A kind of a big recent area that has sparked a lot of litigation is around I put it up there wrong, I always do this, the 1115, not 1511, 1115 demonstrations. So the Social Security Act contains a provision where a state can alter the terms, certain terms, of its Medicaid plan, and as long as it's budget neutral and still fulfills the aims of the Medicaid Act, this is typically permitted. It's typically an experiment that expires in 5 years, and in this way, we have seen states, allocate special funds to address the opioid crisis or some other sort of health care problem in their state. We have also seen work requirements brought forth through a 1115 demonstration, which have had mixed success in the courts. Some courts saying that they serve the purpose of the Medicaid Act, some courts saying that they do not. And look for changes in Medicaid under the One Big Beautiful Bill Act, okay? I call it OBA. So one of the biggest things that the One Big Beautiful Bill Act does is impose a national work requirement in all states. This work requirement is going to apply to let me just say there's a host of exemptions, right? So individuals who are disabled, individuals who are caretakers, a host of other individuals who meet different criteria are going to be exempt from the work requirement, but the work requirement will require that individuals attest to either working or looking for work for a certain period of hours for a certain time, and they have to frequently be revisiting their eligibility for Medicaid under this process. I believe that that does not go into practice for another year, so we are still shoring up what that looks like at the state level. All right, and I'm gonna try and keep marching along so that hopefully we have time for a question or two at the end. The kind of last big bucket of benefits is the individual market. The individual market are for all of the people who don't get benefits in some other way, right? They don't get VA benefits, they don't get Medicare, Medicaid, employer. This is direct purchase from a state or federal marketplace with subsidies, okay? The recent government closure had to do exactly with this, right? Who qualified for subsidies was the debate over the government shutdown. This is a heavily, heavily regulated market under the Affordable Care Act, right, the federal law. Also, there's a lot of state governance of this through the benchmark plans that kind of model exactly what the benefits have to cover in that state. This was a highly discriminatory market pre-Affordable Care Act. If you had any health condition whatsoever, your premiums would be higher or you might not be allowed to enroll. So the ACA requires that insurers who are participating in the marketplace have to issue plans to everybody regardless of their health status. They have to renew those plans as long as you pay your premiums. They're not allowed to discriminate in terms of eligibility based on health status. They can vary your premium, but only for a few criteria. So age, tobacco use, geography, or family size, that's it. Otherwise, they're not allowed to vary the premium at all. And they have to cover 10 categories of essential health benefits. The rubber hits the road at the state level here with benchmark plans and looking at exactly what benefits are covered under those 10 essential benefit buckets. Here we have a federal floor with the Affordable Care Act. We have additional state laws that might apply to the private insurers who are offering these plans on the marketplace. And then we have contract law that's coming in around things like the terms of coverage. Okay. Let me say a couple things about delivery and payment. And I know that other folks are going to pick up more on this in the next couple presentations. So I'm just going to sketch a very basic overview of how this system works in terms of how money flows through the system. So, and this probably won't surprise anyone in the room, we start with the patient. The patient is paying direct premiums to an insurer typically, or potentially to a government body. So the payer is receiving premiums through government money, through private money from the patients. On the provider side, the patient is seeking care directly from the provider, okay, whether that be a public or a private individual. The provider seeks reimbursement from the payer, and the payer then pays the provider and processes claims, okay? There's different kinds of mechanisms for some of this claim processing, and I think folks will pick up on some of this later today. The things that where the money are flowing, the patient is paying their out-of-pocket expenses, their premiums, and their cost sharing, so their deductibles, co-insurance, all of that kind of thing. The provider is using a standard set of codes to explain to the insurer what they're doing and how much they should be compensated for based on the skills that they're delivering, the services they're delivering. And then the payer is adjudicating the amount of coverage, right? whether the benefit should be covered given the service, given the person receiving the service, given who the provider is, given the laws that are applying to the payer in terms of what they have to cover and don't. Okay? Increasingly, this process has a lot of AI involved in it, okay? Which might be something interesting to kind of talk about, and which some of you might be really familiar with. Healthcare payment models, there's a few different models that are possible, and again, I think that people are going to talk about this more. There's a fee-for-service model, which essentially means that for each service you're paying, you get a particular volume of money, and you pay every time the service is provided. And this is your typical Part B and your commercial insurance model, okay? This is also critiqued sometimes for being a reason why healthcare is so expensive, because, you know, if my doctor gets paid every time I show up, right, with a runny nose, then there's maybe not a lot of incentive for them to actually treat the runny nose, as opposed to just having me come back over and over with the runny nose, okay? So fee for service is, I did this thing, I bill based on this code, and then the insurer pays out for it. Capitation, we see this more on the managed care side, Part B or Part C, Medicare Advantage. This is a lump sum to deliver care to a certain population, and so there's a little more incentive on the part of the providers to make sure there's not repeat patients, okay? But there is risk of undertreatment, that providers are saying, you know, we only get so much, we don't want to spend too much on any particular individual. Bundled payments, we see this where there's a single episode of care that has sort of a lump sum around it, right? So like obstetric care, and there's multiple codes or multiple services maybe rolled into one. We see this in certain diagnostic related groups that kind of lump those services together, and you can bill more easily in that way. And then value-based care, this is a newer and experimental model in some parts of the healthcare finance world, where we're trying to pay providers more for outcomes than for just basic delivery of services. So accountable care organizations, Medicare shared savings programs are all attempting to have sort of a basic amount of payment for service, but then bonuses if certain outcomes are met that the provider gets to share in when the insurer saves money. Okay. This is where I feel like the presentation, so I'm going to wrap in just a second, but I could then start to talk about 100 different important health laws and regulations that you should know about, but I don't have time to do that. So instead, I'm just going to emphasize one thing, which is that the Medicare and Medicaid system, the spending of federal money in the healthcare system, for us as lawyers, it often creates a sort of regulatory hook, right? Where Congress then feels that it can now regulate in that space. Now, of course, Congress could regulate based on a stream of commerce as well, but they don't always do that. Where you often see laws in the healthcare space is when a party accepts Medicare or Medicaid money. At that point, then what we see are a host of statutes, regulations, et cetera, that come along. So some of the ones to highlight as examples: the fraud laws are typically applying predominantly in the context of federal fraud. So anti-kickback, Stark, false claims, the spending of federal money, looking for loss of federal money. EMTALA, the law that requires that emergency rooms screen individuals for emergency conditions, is something that only applies to ERs that accept Medicare. Conditions of participation, Medicare and Medicaid have COPs that providers have to agree to as a contractual duty to accept Medicare money. Civil rights and anti-discrimination laws. When John F. Kennedy proposed the 1964 Civil Rights Act, he said that civil rights should not be abused through the use of federal dollars. And so what we have is a system where the minute you take federal money, you now have to comply with a host of anti-discrimination laws. The Physician Payment Sunshine Act, where you have to disclose certain financial conflicts, is another example. Okay? So this to say that to understand what any particular party is having to navigate in the legal space in healthcare, you often first have to know who the party is and what kinds of sources of federal or financial assistance they're getting. If they're Medicare and Medicaid participants, there's going to be a very different set of laws than if they aren't. They most likely are, right? They most likely are. Almost every healthcare actor in the country is. But with these, you get a host of kind of legal challenges. Okay, I'm going to wrap there and see if there are questions. I hope that was general enough, but not too general. That's the challenge with this presentation, I think. No? A quiet group. Yeah.
I think it might be helpful if you could just speak to the difference between federal regulation of healthcare and state regulation. The different subject matter, different. When are we going to be looking to Tennessee law to answer the question?
Yeah, I actually think, so the federal kind of the finance stuff is typically going to be federal law, unless you're dealing with private insurance. And then even then, there's a massive way in which a lot of employer plans can avoid state law through ERISA. So you may, depending on if it's a payer issue and it's commercial, you may have state law that's applying, but often it's more federal law. Where you typically see state law more is in questions of quality and safety. And again, this is a little bit of a generalization, but physicians and other healthcare providers are licensed through the state. So if you have a person who potentially has a malpractice case or a disciplinary issue, state law is going to govern there. The question of licensure of facilities, safety requirements around facilities, often has a state dimension to it, state law dimension to it, although, Medicare and Medicaid also require these obligations, and so there can be a kind of a federal component to that as well. So I'm trying to think if there's anything I'm missing. I would say that you have to kind of be on the lookout, right, for both, right? But generally, the finance tends to have an important federal component, not always, but mostly, and quality and safety tend to be state licensure and things like that. So that's a good, yeah, but that's simplifying, right? Yeah. Oh, okay. Anything else? Any other? No? Okay. All right, that's all I got. That's all I got for you. Thank you.
Thank you very much.